Hi everyone, my name is Faustine Ramirez and I'm a master tutor for MedSchoolCoach, and today we'll be reviewing a Step 2 CK question. So let's get started and read the STEM. A 26-year-old woman is brought to the emergency department by ambulance. Her roommate called the paramedics after witnessing a generalized tonic-clonic seizure. Review of her medical records reveals that she has a history of depression and hypothyroidism, but there is no known history of epilepsy. Upon arrival, she is somnolent but arouses to painful stimuli. Temperature is 38.2, heart rate is 128, respiratory rate is 20, and blood pressure is 83/51. Oxygen saturation is 95%. On examination, she is flushed and diaphoretic. Pupils are 6 millimeters and poorly reactive to light. Mucous membranes are dry. Her airway is patent, and her pulmonary examination is unremarkable. Her abdomen is soft, mildly distended, and bowel sounds are absent. She is placed on 2 liters of 100% oxygen by nasal cannula, and a normal saline IV bolus is initiated. Serum glucose is 85, and other laboratory studies are pending. Electrocardiogram reveals sinus tachycardia and cure restoration of 130 milliseconds. What is the next best step in management? So I'd like you to pause the video for a moment and try to work through this question on your own first. All right, welcome back. So let's work through this question together. So as always, the first step when we approach a question is always to read the very last sentence, so to read the question itself. So what is the next best step in management? So this is going to be a management question. And we glance at the answer choices and we see that they are a combination of some medications and maybe a few other interventions, mostly pharmacologic interventions. So we don't need to spend too much time looking at these, just a couple seconds. We glance at them, we know already what some of our options are going to be, what types of responses the answers are, and then we start reading the STEM from the top. So let's highlight the key elements here. 26-year-old woman is brought to the emergency department by ambulance. Her roommate called the paramedics after witnessing a generalized tonic-clonic seizure. Review of her medical records reveals that she has a history of depression and hypothyroidism, but there is no known history of epilepsy. Upon arrival, she is somnolent, but arouses to painful stimuli. Temperature is 38, heart rate is 128, respiratory rate is 20, and blood pressure is 83/52. Oxygen saturation is 95%. So when we're reading a STEM, it's really important to highlight what the past medical history is, because often that's going to be a really important clue. So here we're told she has depression and hypothyroidism. We also want to highlight the key elements from the presentation. So she initially had a tonic-clonic seizure. Now she has some somnolence, but she is arousable. And then I always recommend to highlight abnormal vital signs because often they're really important clues into what's going on. So the patient has a fever, is tachycardic, is slightly tachypnic, and is hypotensive. And the oxygen saturation is acceptable. It's not perfect. We would like to see it more in the high 90s, but it's still relatively appropriate given everything else that's going on. On examination, she is flushed and diaphoretic. Pupils are 6 millimeters and poorly reactive to light. So boards questions will often, instead of telling you that pupils are constricted or dilated, will give you how big they are in an actual measurement form. They might do the same thing for reflexes or pulses. They might say that they're 1+ or 2+ or 3 pulse. So you do need to know what the normal is for pupils. And so the normal could be, depending on the situation, somewhere near like 3 to 4 millimeters. So here 6 millimeters is a dilated pupil, and we're told they're poorly reactive to light. So this patient has mydriasis. Mucous membranes are dry. Her airway is patent, and her pulmonary examination is unremarkable. Her abdomen is soft, mildly distended, and bowel sounds are absent. So to interpret this exam, to put it into words, other words, we have dilated pupils that are not very reactive, dry mucous membranes, and a mildly distended abdomen with absent bowel sounds, so concerning for potentially an ileus. And the patient has hyperthermia, fever, tachycardia, slight tachypnea, and hypotension. She's placed on 2 liters, 100% oxygen by nasal cannula. The normal saline IV bolus is initiated. Serum glucose is 85, which is normal. Other laboratory studies are pending. Electrocardiogram reveals sinus tachycardia and a QRS duration of 130 milliseconds. So again, we have to know what the normal is to know whether this is normal or prolonged. So you may remember that a normal QRS on the upper limit of normal is about 120 seconds, or milliseconds, I'm sorry. So even when once we're getting into the 100 range, it's starting to be slightly long, and 120 is the upper limit of normal. So 130 is definitely a prolonged QRS. So this patient has tachycardia with prolonged QRS. So before we go and take a look at the answer choices, let's take a moment to put these different pieces of the puzzle together and identify what the underlying diagnosis is. Remember, for boards questions, often they're two-step questions. The first step is to identify what the diagnosis is, and the next step is to answer a question about it. So let's jot a few things down and put some of these pieces together. So the main elements from the presentation are going to be the presence of a seizure. So it doesn't exactly matter whether it's generalized or focal, but we have a seizure. We have some altered mental status, including somnolence and just being altered and not super responsive, although she does arouse to painful stimuli, so she's not in a full coma, but has decreased responsiveness. We also have some vital sign changes, right? So we have a fever, tachycardia, tachypnea, hypotension. And then what's going on with this exam? So putting these pieces together, flushing, dilated pupils, dry mucous membranes, and ileus, this may be a red flag for a certain pattern that you should be able to recognize for boards questions. And so this pattern of findings, the physical exam findings of the dry mouth, the dilated pupils, the ileus, and the flushing, putting these pieces together, this should make you think of anticholinergic toxicity. And actually these vital signs are part of this picture. So I did separate them out, but I would say these go together in terms of the abnormalities that we would see in anticholinergic poisoning or toxicity. We would also see hyperthermia, tachycardia, and we can see hypotension. So these vital signs are just a manifestation of this anticholinergic toxicity. And then finally, we have some findings on EKG where we have tachycardia and, most importantly, prolonged QRS and some QRS widening. So taking a step back, putting all these pieces together, this is a classic presentation for a very commonly tested toxidrome. So if you don't remember what it is after this question, hopefully you'll never forget this again. So putting these two pieces together, we have CNS involvement. Putting these two pieces together, we have anticholinergic involvement. And putting this piece together, we have cardiovascular, specifically conduction abnormality. So we'll just call this CV. So these are the 3 C's of TCA toxicity. So this is a toxidrome that you should be able to recognize in any question now on the boards. CNS involvement, including seizures, altered mental status, sedation, anticholinergic toxicity, including all these findings we said here, and then cardiovascular involvement. This can present classically with conduction abnormalities, and the most common one is going to be prolonged QRS, and we'll talk a little bit more about some of the others. So the 3 C's of TCA toxicity. And so another big clue here was that this patient actually had a history of depression. Now, we're not told what medications she's on, but when we're given a personal history of depression or anxiety or any psychiatric history, you should already be thinking about which psych medications could be causing the symptoms that you're presented with, right? So psych, very commonly tested toxicities of the medications. TCA toxicity is one of the more commonly tested toxidromes, so you should be able to recognize this pattern anytime you see it moving forward. So let's learn a little bit more about TCA toxicity before we look at these answer choices, specifically about the management. So you may have been able to recognize this was TCA toxicity, but you do have to know some specifics about how to manage it. So clinical features we mentioned already, we'll move through these quickly. CNS involvement, cardiovascular, conduction abnormalities. You can also get wide QRS, but also other prolonged intervals. The feared complication here is ventricular arrhythmias, especially VTach and VFib, as well as tachycardia and hypotension. And anticholinergic poisoning, including dry mouth, blurry vision, dilated pupils. You might get urinary retention, flushing, hyperthermia, absent bowel sounds, or even an ileus. So in terms of management, so the first thing you want to do in TCA toxicity or overdose is manage your ABCs. So we were told that the airway was patent. You want to make sure that the patient is not so sedated that they're not going to be able to breathe on their own. If they're that sedated, they should be intubated. You want to look at their breathing and their oxygen saturation, and they may need some extra oxygen, which we did give this patient a little bit of extra oxygen because she was slightly tachypnic and her oxygen saturation was kind of borderline, although certainly still appropriate. And then you want to give some isotonic normal saline boluses for the hypotension that you would see as part of this toxidrome. So we would use normal saline here, and we would do this in a bolus rate rather than a maintenance rate to get that fluid in quickly. So this would be fluid resuscitation rather than maintenance. Next, the next intervention you can consider is activated charcoal. Now this has very specific times when you can give this. So first, it has to be within 2 hours of ingestion. So we weren't given a time frame here, so that wasn't going to help us differentiate whether or not we could use activated charcoal. But it's also contraindicated if the patient has an ileus or any evidence of intestinal obstruction. And in this patient, we had absent bowel sounds and some abdominal distension. So there were some concerns about the abdominal exam, although minor. The absent bowel sounds certainly clued us in that she may have an ileus, so that would have been contraindicated. We also want to avoid activated charcoal in sedated patients who might not be able to protect their airway and who might aspirate. So I would say both of these were concerning enough in this patient, even without the time frame where we would avoid activated charcoal. And if we were given a time frame that was more than 2 hours, that would have also been a contraindication. Now, the crux of this question was based on your knowledge of this aspect of management here, which is administration of IV sodium bicarbonate for EKG abnormalities, specifically QRS widening, even as early as greater than 100 milliseconds, because of the risk of deteriorating into VTach or VFib with TCA toxicity. Even if 100 is still within that normal range, once you get above 100, you're more likely to be at risk of developing these ventricular arrhythmias, so that would be an indication to give sodium bicarb. If they already had ventricular arrhythmias like VTach or VFib, that would also be an indication to go ahead and give sodium bicarb. So in the setting of TCA toxicity, any electrocardiogram changes, specifically QRS widening or ventricular arrhythmias, would be indications to give sodium bicarb. So these work by alleviating the effect of TCA on the myocardium sodium channels. So if there's a question about mechanism, it acts by alleviating the drug's effect on these myocardial sodium channels. And you want to avoid class 1A and class 1C antiarrhythmics. You don't want to give procainamide or flecainide, for example. Although these are conduction abnormalities, you want to avoid these types of antiarrhythmics. And then finally, for seizures, the drug of choice is benzodiazepines rather than phenytoin. So if the patient was still actively seizing when she arrived to the emergency department, we could have given benzodiazepines, but phenytoin is not an appropriate choice. And then finally, although she does have signs of anticholinergic toxicity from the TCA toxicity, even though this is technically given for anticholinergic toxicity, in the setting of TCA overdose, we want to avoid physostigmine, which is an acetylcholinesterase inhibitor, which is typically used in the setting of anticholinergic poisoning. However, in this case, even though we do have some component of anticholinergic poisoning, physostigmine has actually been associated with cardiac arrest in the setting of TCA overdose. So we would not give this in the setting of TCA overdose. We would only give it if it was exclusively anticholinergic poisoning, but not any of the other findings. So again, avoid physostigmine, although typically we use this for anticholinergic poisoning. We don't in the setting of TCA overdose. So taking a look at these answer choices again, let's work through these. So physostigmine, like we said, is not safe to use in the setting of TCA overdose. Procainamide, we're not going to use this specific antiarrhythmic, as we learned already. Metoprolol would be helpful, but perhaps in a different situation with where the patient had tachycardia, if we were, concerned about the patient being in AFib or some other situation where we wanted to reduce the heart rate. But here the blood pressure is already quite low and there's no indication, we want to treat the underlying cause here. There's no indication to bring down the heart rate just to bring down the heart rate. It's not all that fast, and that's not what is causing this patient to be hemodynamically unstable. So we don't want to give this. Naloxone is used in opiate overdose, which is a different toxidrome that is not in this question, but would be useful in a different question on opiate overdose. Phenytoin, we learned that we don't give for seizures and TCA overdose. We would give benzodiazepines instead, so that's wrong. Sodium bicarb, we can leave this one for now. Flecainide, we learned that is not an appropriate antiarrhythmic to use in the setting of TCA toxicity. And then finally, activated charcoal, as we mentioned already, we're told that bowel sounds are absent and that she is definitely somnolent, and so she may get more sedated and be at risk of not being able to protect her airway. And there's concerning findings that she may have an ileus or be developing an ileus, so that would not be an appropriate indication to use activated charcoal. So the correct answer was F, sodium bicarbonate. All right, so that wraps up our question of the week. Thanks so much for listening.